I'm also the founder and director of a company called Clearwax, and Clearwax are the manufacturers of the wireless eye ClearScope endoscope device that we're using to perform and record the procedure. We also train ear professionals around the world in endoscopic ear care, and if you are based in the UK and you want to find your local earwax removal specialist, please visit our website www.clearwax.co.uk, enter your town, your postcode, and you will find a list of your nearest specialist. So this patient attended a couple of days ago. It was an elderly patient of mine. He is a chronic wax sufferer, so he does suffer from ceraminosis. Ceraminosis is the medical term for chronic earwax infection. We're starting off with the left side, and the earwax is very dry and crumbly. There's a lot of keratin attached as well. You can see there just to the left, so on the anterior canal wall, there's a bit of keratin there, and this dry piece of earwax that I'm wriggling forwards. Dry earwax can sometimes be slightly uncomfortable for the patient to remove because the outer surface can be quite coarse and rough, and as you're extracting that wax, it can graze and abrade the ear canal. But in this instance, the patient was fine. So making good progress, making good headway here. And as the case, whenever you're removing earwax, we make these gentle wriggle motions to help detach the wax from the canal wall. So the ear canal is around 3 centimeters in length, about 8 millimeters in diameter, and it's coated by a thin layer of epithelial skin cells. The skin that lines the outer third of the ear canal, so the cartilage portion, is about 1 millimeter thick, and the skin that lines the inner 2/3, so the bony part of the ear canal, is about 0.1 millimeters in thickness. And as that skin dies and sheds, it naturally migrates out of the ear, so it's like a conveyor belt. And as it sheds and naturally moves outwards towards the entrance of the ear canal, it expels with it any earwax that it's secreted. So it's the hair follicles on the outer third. We have the hair follicles on our scalp. These are the sebaceous glands, and the sebaceous glands secrete a substance called sebum, which is rich in long chains of saturated and unsaturated fatty acids, alcohol, squalenes, cholesterol. There's also modified sweat glands called apocrine glands, so they're known as the ceraminosis glands. They are also found around the hair follicles in the outer third. And so as the ear secretes sweat and this sebum substance, it then combines with dead skin, that's shedding, and that amalgamates into earwax. And 60% of earwax is known to be dead keratin. You can see we've just got a bit of dead skin here that on the anterior canal wall that we're trying to peel. Approximately dead skin sheds and migrates outwards at the same rate as our fingernails shed and grow. So looking, I think around 3.4 millimeters a month, if I'm correct. So that's approximately less than 0.1 millimeter a day, or around that much. So what I want to do with this patient, because of COVID, and he is quite elderly, he's quite vulnerable, so I was just trying to remove as much of the dead skin as possible, that's safely possible. You'll see the right ear after we finished the left ear, that ear was a lot more complex, there's a lot more wax, and we just had to leave some soft residual wax in that ear. A bit of wax is healthy for you. With the right side, the patient had suffered from the caloric effect, he got a bit dizzy, which can sometimes happen when we remove earwax using suction. It can also happen with irrigation or syringing. That's because the organ of balance, so inside the inner ear, we've got the organ of hearing called the cochlea, and we've got the organ of balance, which are 3 semicircular canals, and they are actually combined in one structure. The organ of balance can be affected by temperature and pressure. if we raise the temperature in the ear, it excites the balance organ in that particular ear. So that balance organ is hyper-functioning compared to the balance organ in the opposite ear, and therefore the brain receives mixed messages, and the brain thinks you're moving but you're not, and then your eyes try to correct your brain and you get vertigo, the room spins around, and it can settle quite quickly with the chronic effect. You're looking around a minute or so. With microsuction, it actually reduces the air temperature performing the procedure in. Nonetheless, it's the same effect. Your brain's getting mixed messages from both organ of balances. One's functioning normally, one's under-functioning, it's hypo-functioning, and therefore your brain thinks, because of this miscalibration and you're not physically moving, your brain thinks, what's going on here? I'm confused, and you suffer from vertigo and the room spins around, and that's when your eyes try to correct your brain. And it takes about a minute or so. Some of you may suffer from vertigo when you lay down in bed and turn over to one side. That's called benign positional proximal vertigo. And it's when there's crystals inside the inner ear, the organ of balance, and they get dislodged. And when you lay down in bed and turn over to one side, these crystals enter a part of the ear where they shouldn't be. And then once more, it's telling your brain that you're moving, but you're not. And then your eyes try to correct your brain, and you can suffer from violent vertigo for about a minute or so. And some people do feel sick and nauseous as well. And then it settles down. And then there's an exercise called the Epley maneuver, which can help reposition those crystals back into the correct part of the organ of balance. So they kind of generally move from one semicircular canal to the horizontal, actually. And then you're just trying to reposition them. Back to the procedure. Sorry about that, just got a bit carried away. I enjoy talking about the ears, and I've been reading a lot of the comments recently. And as I said, this channel's always been designed to be educational. I know it's quite entertaining for some people, and a lot of people find it satisfying, but a lot of medical students and audiological peers and colleagues do watch the channel, and they do like explanations of all things ears. It wasn't actually at first a channel dedicated for earwax removal. It was an audiological channel, but obviously the main content I'm putting up is earwax removal procedures. So with the right side again, we're just tunneling through. The wax is a bit softer in this ear, it's not as dry. There's still a lot of keratin that's coating the ear canal wall. And you can see there's a lot of hair silhouette near the entrance. So I'm just peeling some of this skin that's lateral. Lateral means near the entrance. You tend to find older patients have a lot of dead skin in the ear. And if I remember correctly, with this patient, they weren't able to lift their head into a normal position. The head was tilted forwards and downwards. So I have got an ENT stool, so I did put it down to the lowest possible level, but I still couldn't get access into the ear. So I think, if I remember correctly, with this patient, I actually got off the stool, and as I was kind of almost bending, and that's what's great with endoscopic earwax removal, because of the iClearScope, because it's very portable and lightweight. If a patient isn't able to position the head the way the clinical ear care specialists would like them to, you're still able to manipulate the iClearScope and just reposition yourself. If you've got a big operating ENT microscope, well, it's a lot more difficult to get that in position if the patient themselves are not able to be in the correct position. With an ENT operating microscope, typically patients are laying down on the couch, and occasionally you do get some patients suffering from vertigo, BPP. If they've got BPPV, when they're lying down on the couch, they can get momentarily dizzy. But it's typically when you're tilting your head back beyond the horizontal and to one side. So we've just got this residual wax, soft wax, that's impacted on the eardrum. The reason why the wax is a lot softer and wet on this side is the patient had been using some earwax drops. I think it was hydrogen peroxide drops. If you've been watching my videos, you know I'm not a big fan of hydrogen peroxide drops. One, it's water-based. Water's really bad for the ear. We want to avoid water in our ears, and that's true for everyone. Also, hydrogen peroxide drops are slightly alkaline in pH. The ear is naturally acidic. Earwax is also naturally acidic, and it's believed the acidity in the ear has antimicrobial effects, so it inhibits certain bacterial growth and fungal growth. And if you're using hydrogen peroxide drops, you're turning the pH in the ear canal from an acid to an alkaline pH, which is then you're a bit more likely to get irritation in the ear and develop an ear infection. Still very low risk, but I have come a few patients who use hydrogen peroxide drops and sometimes sodium bicarbonate drops that develop ear infections as a result of their use. So I'm just using a fine end gauge. I'm just kissing the surface of this anterior medial bony part of the ear canal. As you know, if you've been watching my videos, don't worry about that hairs. I think that's paused. Oh, that's come back again. Sorry about that. There was a video, I think a couple of weeks ago. I've got to rewatch it. People were really complaining about a hair that was near the eardrum, and I think I eventually got it out, but I can't remember it. But it was driving a lot of viewers crazy, so I need to watch that back. I've got a lot of hair in my ears, and it doesn't generally cause any problems. For some people, yes, I've had to remove hair from the ear canal and near the eardrum where it's possible to do it safely, because they do find it tickles their eardrum or their ear canal. But generally, people don't notice hair. But everyone's different. Everyone's got different sensitivity levels. So I'm just mopping up near the entrance here. There's a bit of dead keratin, a bit of dead skin. Oh, I do hope the patient say if this hair was causing any irritation for the patient, I'm sure they would have told me, but I think I did get it out. Let's fingers crossed. So there's some dead keratin anteriorly. This keratin's not, it's a bit more stubborn. It's not really ready like it was in the left side to be peeled, but I just wanted to see if it does. Sometimes you just get it from the base like we are now and it all peels off in one go. But in this case it doesn't, it's just peeling anteriorly. So this piece of keratin came out, it's more lateral, so it did peel off nicely. So a bit of earwax, guys, is actually, it's not going to do the patient any harm. Everyone has natural earwax. Even if you don't visibly see it when the doctor looks in your ear, for example, it coats the ear canal. Earwax is, as I mentioned before, slightly acidic, so it has antibacterial properties and antifungal properties. Earwax is also quite sticky, so any dust, dirt, foreign particles, pollen that enter the ear canal, it sticks to the earwax. And as the earwax naturally migrates, which is the norm for 90 or 95% of people, it's only 5 or 10% of people that don't have that natural migration, hence why they get earwax impaction. So as the wax naturally migrates, it expels with it all this dust and dirt that is trapped, and earwax is slightly greasy and oily because of that sebum that's secreted by the sebaceous glands, and the oil and the oily fatty substance helps lubricate the ear canal wall, the skin, preventing it from drying and cracking. So again, we're just on the anterior canal wall, so the front part of the ear canal. So this section of the dead skin up until then was moving fine.